Good afternoon, everybody. It's the turn of Gynae Unit 1. So there's a famous saying which says that you cannot step into the same river twice. I.e., you may have situations which may be similar, but the experience are always different. Renal transplant and pregnancy is one such situation. We presented renal transplant pregnancies in one or two occasions earlier, but our experience with each patient has been very different. So, keeping with that sentiment, today we present a pregnancy after a renal transplant, and we have Sushma, Soni, and Sonia. Dr. Sushma from the JR side to present the story, Dr. Soni who will be reviewing literature, and Dr. Sonia who will take the Q&A. So I'll hand over it to Sushma to take you through these complex case and how it was very well managed by a multidisciplinary team effort.
Thank you, ma'am, for providing this opportunity. Good afternoon, everyone. I am presenting a case of Mrs. M. She is 29-year-old female, resident of Delhi. She is postgraduate and a homemaker. She is non-case of chronic kidney disease, stage 5, for which she underwent live donor kidney transplant in BLK Hospital 2018. After 6 years of successful graft survival, she conceived spontaneously, second time with history of previous one pregnancy loss. She presented to us at 13 weeks of gestation for antenatal booking. Her first trimester was uneventful, and she was on immunosuppressant as a thiopurine, prednisolone, and tacrolimus. After reviewing her OBS history, she had previous one spontaneous conception in 2023, for which she was booked in Trusty Care Hospital. Her pregnancy was uneventful till 6 months of gestation. After 6 months of gestation, she developed preeclampsia with severe feature and underwent emergency preterm cesarean section at 27 weeks for impending eclampsia with reverse end diastolic flow. And she delivered a severely growth restricted baby of 670 gram who expired on day 26. In this pregnancy, she was booked to us at 13 weeks period of gestation. At presentation, there was no complaint. On examination, her vitals were stable. Investigations reviewed indicating a stable graft function. Aneuploidy screening was done for fetus, which was also normal. As a kidney transplant recipient, she was keen to continue her pregnancy, but she was concerned regarding risk of graft failure if she continued her pregnancy. Will her kidney disease progress or not during pregnancy? What happened to her immunosuppressive dose therapy? Will drug affect her baby? With this all concern, she was in dilemma whether she should continue her pregnancy or not. Now, after proper evaluation and discussion with experts, we found that this is the optimum transplant to conception interval and her graft function was also stable. After reviewing her drugs, that is category C drugs, explaining her risk and benefit ratio, she was counseled to continue the pregnancy and started on ecosprin for preeclampsia prevention. Now, her pregnancy was uneventful till 25 weeks gestation. On antenatal visit, again her BP was recorded as 150 by 110 because she has history of preeclampsia in previous pregnancy at same period of gestation and there is risk of graft failure. She was admitted for fetal-maternal surveillance and optimization. Her pH profile was sent, which was normal. To rule out preeclampsia, preeclampsia screening was also done, which was normal. Fetal surveillance was also normal at that period of gestation. Finally, based on clinical findings, elaborated parameters, she was diagnosed as gestational hypertension and started on labetalol 100 mg thrice a day. She was advised to continue ecosprin and same dose of immunosuppressant, discharged with a plan of weekly monitoring. After 1 month, again on antenatal visit, her BP record spiked to 156 by 100. On examination, gravid uterus correspond to 26 weeks, indicating fetal growth restriction. With this raised BP record, despite being antihypertensives and significant rise in serum creatinine within 1 month from 1.1 to 1.6 milligram per deciliter, rising proteinuria from 100 milligram per gram to 850, and E. coli on her culture sensitivity report, we were in dilemma whether it is preeclampsia with severe feature or graft rejection because management of these two conditions are totally different. If it is preeclampsia with severe feature, it may require premature termination of pregnancy. But if it is graft rejection, she can continue her pregnancy with close monitoring and immunosuppressant dose modification. She was admitted and further evaluation was done because of falling plate because her serum creatinine was because of her deteriorating renal function, rising LFT, and falling platelet, more likely the possibility of preeclampsia was made. But there is less likely possibility of graft rejection. To confirm our diagnosis, further evaluation was done. SFLT-PSGF ratio is a ratio of anti-angiogenic factor with angiogenic factor. It's a novel biomarker which is used to predict risk of preeclampsia. Is prediction semi-renal transplant recipient, and to rule out graft rejection, we need renal biopsy. But is renal biopsy safe in pregnancy? We proceeded with acceptability PLG ratio, which came out 84.4, 84.5, which indicate high risk of preeclampsia. So probably the diagnosis of preeclampsia was made. But to confirm our diagnosis, we also need to confirm our diagnosis, we need renal biopsy. Now I would like to invite our pathology colleague to describe features of renal biopsy on graft rejection.
So this was the case of 29-year-old female patient. We received single core which is fragmented, and also there is a fragment of skeletal muscle tissue was also present. So at low power we can see this is a single core with 8 glomeruli and 1 artery which is qualified for BAMF adequacy, and none of the glomeruli are globally sclerosed. And low power itself we can see the presence of IFTA which is approximately 15%. This is higher power to show the same. These are the region of IFTA and here tubular atrophy, and also there is presence of chronic inflammation in the IFTA region, not in the non-scarred kidney or non-scarred kidney renal cortex. These are the microphotograph of glomeruli which show no significant features of glomerulitis, mesangial matrix expansion, or any reduplication on the silver methanolamine stain. In this power itself, we can see arteries shows mild fibrointimal thickening. This is the region of scarred kidney. Here we can see the presence of pericapillaritis, which qualify as PTC score 1, and also artery showing hyaline in its wall, which is qualified as AH score 2, and also there is mild fibrointimal thickening, which is qualified as CV score 1, but there is no features of any arthritis or any thing like that. But in this scarred region, there is presence of to moderate mild tubulitis in this scarred region, but non-scarred kidney does not show features of tubulitis. This is the C4D immunostain, which is negative. This is SV40 immunostain, which is negative in this case. And this is the C4D stain. This is the non-specific entrapment in the mesangium. So the direct immunofluorescence cannot be performed as we have received only fat in the tissue, and for electron microscopy no tissue was seen. This is the BAMF score for this case, and the diagnosis was given as no morphological evidence of rejection and IFTA of grade 1. Thank you.
Finally, diagnosis of graft failure was ruled out, and we proceed with our diagnosis of preeclampsia with severe feature. And because she is just 32 weeks period of gestation and she developed preeclampsia, we planned her to monitor intensely for fetal-maternal surveillance. For her to control her BP, her antihypertensive dose escalated to levodopa 20 TDS and nifedipine 10 mg VDS. Her UTI was successfully treated with IV antibiotics. During fetal surveillance, fetal core restriction and worsening Doppler. Antenatal steroid was also given in view of risk of preterm delivery, and patients were counseled regarding possibility of preterm termination of pregnancy, prematurity of baby, NICU stay, and renal deterioration during pregnancy. At 31 plus 3 weeks period of gestation, baby developed RADF on umbilical artery Doppler with spontaneous decelerations. Decision for delivery by emergency cesarean section was taken. She underwent cesarean section on 26 December and delivered a baby of 1.5 kg with Apgar 8/9. Intraoperative, she had blood loss of 800 ml, and in view of moderate anemia, she received 1 packed digoxin, 3 RTPs. During her post-operative course, her BP was controlled on amlodipine and clonidine. She again developed UTI on post-op day 2, for which IV antibiotics was given. Her proteinuria and serum creatinine started decreasing, indicating improvement in renal function. Her liver function was also improved with platelet count. She continued exclusive breastfeeding and she was discharged in stable condition on day 18. Now, her patient and baby both are doing well. Now, I would like to invite anesthesia colleague to discuss her concerns.
So good afternoon to all. Thank you for the kind introduction and conclusion. We will briefly discuss the anesthetic concerns that go into the renal transplant impartition of what type of anesthesia is safe for a patient with renal transplant presenting for cesarean section. So we commonly encounter these patients either for liver anesthesia or for anesthesia for cesarean section. But there is a thin line decided general anesthesia or regional anesthesia for these patient. So we carried out anesthesia for this liver transplant, for this renal transplant with CDN at 31 weeks, at 37 weeks of gestation, and we had subarachnoid block spinal anesthesia for this patient. So, what are the basic anesthetic considerations that help us in deciding which mode of anesthesia would be suitable for these high-risk patients? First is the effect of pregnancy on renal transplant alpha. Normally, it is seen in the pre-pregnancy graft function is normal. So, it does not, basic pregnancy does not much hamper the renal graft function unless it is compromised by other things like preeclampsia or there is towards the end of pregnancy, there is a rapid compression on the renal graft by the uterus. Also, the second consideration is the adverse effects of immunosuppressants on the mother and the fetus. That, of course, we'll be talking in terms of relevance to the anesthetist. And lastly, we would like to go by the drug interactions that the immunosuppressants commonly have and that help us to decide on anesthetic techniques. So, to start with, pregnancy in itself does not cause an excessive or irreversible problems with graft dysfunction. However, short-term deterioration of the graft function can be seen before and after pregnancy, and especially around term or labor. So, going to the second consideration, the adverse effects of various immunosuppressants in the mother and the fetus that can affect our perioperative management. So, the first, usually the subset of immunosuppressants that are commonly encountered in these patients are the calcineurin inhibitors, like they could be anti-metabolites like azathioprine and mycophenolate, and the commonly used corticosteroids that is prednisolone and methylprednisolone. Amongst the array of adverse effects that these immunosuppressants show, ones that are relevant to us is the inherent nephrotoxicity shown by calcineurin inhibitors. They have a very narrow therapeutic index, so a subtherapeutic or a supratherapeutic dose can both be harmful for the patient. And this inherent risk of nephrotoxicity can also further lead to dyslipidemia, especially sodium, potassium, and magnesium levels. Thus, our purpose during the perioperative management is a keen assessment of the graft function that is usually done by the KFTs or if further needed by our nephrology colleagues within the BPS stand. But during the perioperative management, that is the pre-operative, intra, and the post-operative, an adequate maintenance of renal perfusion is mandatory. How do we do that? We have to avoid hypertension because it has been seen that maintaining a NAP of around 65 millimeters of mercury during the perioperative period is adequate for a previously adequately functioning graft. However, even a 10-minute hypertension of NAP less than 65 can lead to acute tubular necrosis and graft infection in these patients. Also, optimal fluid management, maintaining a urine output of at least 1 ml per kg per hour, both in the intraoperative and post-operative period, and of course, the correction of dyslipidemia that would be also important for management of general anesthesia. Antimetabolites like azathioprine and mycophenolate lead to bone marrow suppression, especially leukopenia, and also the side effects of corticosteroids, as we all know, increases the risk of infection. So whether it be general anesthesia or regional anesthesia, strict asepsis during AP even intravascular cannula fixation would taking the cannula would also be mandated to prevent any kind of increased infection in these patients. Also, a prophylactic dose of antibiotics, a stress dose of steroids to counteract the perioperative stress of anesthesia and surgery,
as well as blood glucose monitoring. Now, these drugs, especially inhibitors, have been known to cause hyperlipidemia, hepatotoxicity, as well as diabetes in these patients. So, strict sugar control will not only help us counter the side effects of calcium inhibitors, but also decrease our perioperative risk of infection. So lastly, drug interactions. Now these drug interactions often lead to a confusion whether general anesthesia or regional anesthesia would be safe in these high risk patients. So four major criteria that help us to decide whether which mode of anesthesia would be required include the functional status of the transplanted kidney. Now in a patient whose preconceptional status of graft function was adequate as compared to the even in the also in the post-conception phase, so our management remains almost similar to a normal patient. However, there are other factors like cardiovascular status. Cardiovascular status, these patients are inherently at a high risk of hypertension. So, preventing extreme controlling hypertension as well as preventing hypertension becomes essential for our optimal perioperative graft function. Nephrological status, a normal coagulation profile is mandatory for our conduct of regional anesthesia. So, the assessment of platelet function in terms of number as well as the platelet function is important for us, as well as the assessment of the coagulation status will help us to output if regional anesthesia can be given or not. And lastly, indication of cesarean section, that in any part of it helps us to decide the mode of anesthesia. So, in the absence of renal dysfunction, as we discussed, the anesthetic management is similar to that of normal pathogen. However, I would like to conclude by saying that both general anesthesia and regional anesthesia are safe modalities of anesthesia in patients with renal transplant. However, there are certain specific considerations that must be taken into mind. For example, in general anesthesia, as we discussed, utmost importance is maintaining graft function by maintaining hemodynamics and output monitoring. Strict asepsis during intravascular access as well as intubation should be maintained. However, beyond scope of this talk, we will not discuss the drug interactions between the anesthetic and the immunosuppressive. And post-operative analgesia, we should avoid all sorts of methotoxic drugs like NSAIDs, and parenteral operations can be optimal in the patient who has been administered general anesthesia. Similarly, regional anesthesia is equally safe. However, maintenance of hemodynamics, prevention of hypertension, which is a common complication of subarachnoid block, should be avoided. Urine output monitoring is again mandatory. Strict asepsis while performing regional techniques and use of disposables should be encouraged. Epidural abscesses otherwise have been to be common in patients with renal transplant, but the incidence is not very different from other novel pathogens. However, if we maintain strict asepsis, we can avoid undue adverse effects of epidural or regional abscesses. However, checking the anticoagulation, checking the coagulation status of the patient becomes equally important. So I will further move on to the next slide.
Good afternoon. Coming to discussion, the incidence of pregnancy among renal transplant recipients is around 12 to 14%, and managing these pregnancies is always a challenge to us because we have to look from some concerns like perioperative, periconceptual optimization, risk of maternal, fetal, and graft complications, immunosuppressive therapies, safety, and risk profiles. So, the management of the pregnancy is challenged from conception to delivery. In higher stages of CKD, the conception rate is low, that is 0.9 to 7%. But as after renal transplant, the conception rate increases, and it is because of normalization of HPO excess. The transplant in pregnancy affects the graft affects the pregnancy as well as pregnancy affects the graft, leading to some complications like gestational hypertension, preeclampsia around 22%, fetal complications in form of preterm birth, small for gestational age, fetal growth restriction, and teratogenicity. While the pregnancy affects the graft, leading to deterioration of the graft function, acute rejection, as well as graft loss. So, preconception optimization becomes very important. According to all the societies, the waiting period after 1 year is optimum, but according to National Transplant Pregnancy Registry, an ideal candidate should not have rejection in the last 1 year, should have stable kidney graft function, that is, creatinine is less than 1.5 and proteinuria is less than 500 milligram in 24 hours of urinary protein with normal blood pressure, stable immunosuppression, as well as no comorbid factors. Important are no graft dysfunction, any cardiac status, diabetes, proteinuria, obesity, maternal infection, or liver failure. In preconception counseling, drug optimization also becomes very important because these are usually FDA category C, D, or X drugs. So the drugs that are relatively safe in pregnancy are glucocorticoids, cyclosporine, tacrolimus, and azathioprine, and mycophenolate or everolimus or sirolimus should be actually discontinued 6 weeks before conception. The first successful pregnancy in a human transplant recipient was documented in 1963, and since then, around 7,000 pregnancies have been documented in literature in about 5,000 renal transplant recipients. But the risk of complications are also high. As you can see, the risk of preeclampsia is 20%, pregnancy-induced hypertension is 24%, and graft rejection is around 8%. Very few studies have been documented regarding this in India, and one such study is from Ahmedabad, in which out of 211 reproductive age group recipients, only 16 conceived, making the conception rate around 7%. And there were also fetal and maternal complications, around 12%, preeclampsia, gestation hypertension, growth restriction, low birth weight, and rejection was seen in 6%. The cases that we managed at our center, the outcomes of these 4 cases are different. So first is a primary gravida, but with advanced maternal age of 40 years, spontaneous conception with transplant to conception interval of around 18 years, but she had a bad complication, that is development of preeclampsia with severe features around 25 weeks with reversal of flow and subsequently IUD. Our second case is a primary gravida, 28 years, spontaneous conception, who subsequently developed gestation hypertension and growth restriction around 32 weeks and post UTI in the postpartum period and delivered a low birth weight baby. Our third case is a cadaver transplant, primary gravida, 33 years, spontaneous conception, whose pregnancy went uneventful till 36 weeks of gestation, when she developed gestation hypertension but delivered adequate for gestational age baby. And the fourth case that we discussed, in which we had dilemma of graft rejection and preeclampsia. So differentiating graft rejection from preeclampsia in kidney transplant cases is really challenging, and there are very few studies in the literature about it. So one such study is given by Yin et al., in which there were 2 groups, biopsy confirmed groups, which were 26 in number, and preeclampsia were 76, and all these were kidney transplant recipients, in which clinical and lab characteristics were compared to look for features of graft rejection versus preeclampsia. The maternal and fetal outcomes were comparable. However, in the cases of graft rejection, serum creatinine was elevated by 73%, while in case of preeclampsia, more of proteinuria was seen. In case of graft rejection cases, the graft survival was also less, that is around 27%. However, graft loss was seen in both the cases, but 42% in rejection cases. So exploring the new biomarkers for diagnosis of preeclampsia, one such as SFLT PLGF, but its role in diagnosing preeclampsia in case of renal transplant recipients is not well studied, and there are very few studies about it. One such case report is here, in which they face the same dilemma around 32 weeks of gestation, whether this is preeclampsia or graft rejection. And finally, the SFLT PLGF came to rescue, because as the value was 205, they were confirmed that this is severe preeclampsia. The renal biopsy could be avoided in that patient, and the pregnancy continued till 36 weeks. But in our case, as we saw that the value was 84.5, which is actually borderline. So we had to go for biopsy, and we have to get a conclusive diagnosis after biopsy was done, and our pregnancy was prematurely terminated. To graft rejection in pregnancy needs a biopsy, because biopsy is the gold standard for management, for diagnosis as well as management. But there are concerns for biopsy in pregnancy, and once such a systemic review has been documented, in which around 1,500 pregnant patients underwent renal biopsy, and the complications such as bleeding, pain, preterm birth, and infection were noted. The author also concluded that with risk of increasing gestation, that is from 23 to 28 weeks, the risk was 4 to 7%, while it was less in postpartum period, that is around 1%. So, performing renal biopsy in pregnancy
we must weigh risk benefit ratio, and it is safe to perform till 28 weeks only if result is changing the management. So apart from the normal antenatal care that we do, some salient features for managing pregnancy in a renal transplant recipient is that we should do daily BP monitoring, lab investigations, 2400 protein culture every 4 weekly, and start fetal surveillance from 28 weeks. Time of delivery is is at 38 to 40 weeks if there is no obstetrical complication. Mode of delivery is vaginal, and cesarean is only for obstetric complication. Important is that the graft is located in the false pelvis, and hence it poses no difficulty in delivery. But while cesarean section, we should be cautious as we can cause injury to transplanted ureter and kidney. In postpartum follow-up, we should be monitoring the patient for her renal function, proteinuria, blood pressure, immunosuppressant blood levels, and lactation is safe if the patient is on prednisolone, cyclosporine, azathioprine, as well as tacrolimus. Coming to contraception, safe are DMPA implant and IUD, which is WHO category 2. But in case of those recipients who had history of rejection or failure, IUD is MAC WHO category 3 and COCs are contraindicated. Now I'd like to invite my faculty, Dr. Sonia, to further proceed.
So after the interesting case discussion and case presentation, I would like to team from nephrology, Dr. R.K. Yadav sir and his team to proceed further. Thank you.
Good afternoon, everyone. So, as happened in this scenario, first, I would like to start with how we manage a patient who comes post pregnancy, how we manage this transplantation. So, what actually happens in CKD, it decreases the risk, the chances of fertility to as low as 7%. And even if the female conceives, her chances of delivering successfully is only 20 to 40%. Transplant helps in regaining the chances of getting pregnant. However, and it helps regaining these chances within a few months. However, when this female asks us whether she can become pregnant or not, we tell her to wait for a year at least. This has been suggested by both KDIGO as well as American Society of Transplant. This is done so that her graft function is stable, her creatinine is low. So basically, after 1 year, she can become pregnant. We counsel her about the fetal complications as well as about the maternal complications and about the safe immunosuppression, as has been already mentioned. Tacrolimus, cyclosporin, azoran, and prednisolone are safe. Others can lead to neonatal organogenesis disorders. So, tacrolimus also, the problem is the levels may fluctuate during pregnancy and the clearance of tacrolimus increases. In this patient, when the consultation came to us, considering that TAC levels can change in pregnancy, first thing we got the TAC levels done, and the TAC levels were 5.2, which are normal for this period post-transplant. So we went ahead with the biopsy, ruled out all of the DDs, and one by one we reached to the two diagnoses that were either preeclampsia or acute rejection, and went ahead with the biopsy for the same, which ruled out rejection for us. So this has already been discussed that the standard obstetric indications and the safe drugs for breastfeeding are CNI, ASA, and steroids. That was all from our side.
Congratulations to entire team of Obstetrics. Congratulations to entire department of Obstetrics for excellent outcomes in graft feeding as well as fetal. Thank you.
So now we can proceed further with the questions. Yes.
Was when the patient had graft dysfunction, sending out for donors trying on and they before
So there are many options of there was debate to do or not do.
you could not take The naked kidney disease, was that ever investigated? It presented, of course, transplant, but in terms of risk to a child, if you think of what we allowed for genetic kidney disease, what affected her kidney in the first place.
On revealing the history of kidney transplant regarding kidney transfer, it was a very short duration history of 6 months, and patient had only history of some loose motion, vomiting, and diarrhea, and it is very rapid increase in the serum creatinine level, for which it progressed very fast, and renal transplant being conducted in 2018 at outside hospital. Despite that, she didn't have any information and didn't have any further workup regarding the same, and she is following outside only for her renal transplant follow.
Next, we are looking for opening market. Opening market something. So, this is very important.
Any other question? So here we conclude with our presentation, and I would like to thank you all regarding to coordinate and cooperate in this presentation, and for management of the patient, especially from Department of Pathology, Anesthesiology, and very much thankful to Department of Nephrology for providing us the multidisciplinary team so that we are able to manage these patients successfully. Thank you.